Good morning, good afternoon, and good evening for everybody, considering the time zone all over the world. So it's a great pleasure to discuss this information with you. Then I am going to discuss that about surgical intervention for congenital malformations in calves, considering the welfare perspectives. So as you know, as farm animal veterinarians, if you are working in a large scale farms, when you get that calf with congenital malformation, considering the management convenience, we may cull that calf. So that is our basic policy, right? We may not consider about the another aspect of it, right? For the management convenience, we may have to cull that calves. But not only about the large scale farms, we have to think about the small scale farms. Sometimes, as you know, when you go to the field, there are many backyard systems, a household system, different small scale farms are there. So as you know, those farmers are very close with their animals. They may have few cows with them. Sometimes they are calves, and cows may be pet for them, right? Not only for the production, right? They may rear those animals as pets, so they may have a close relationship with those animals. So when they get calves with congenital defects, so they may not allow us to cull that animal, right? Or they may not consider that aspect. They may come to you asking any solution to save the life of that animal. So that is their thought, that is their vision, so that is their requirement. So they may expect something from you to save the life of that calf, or to save the or keep that animal without culling. So under that circumstance, we should have, as veterinarians, as professionals, we should have some solution for our clients, for their satisfaction, and considering about the welfare aspect of the cows, we have to consider about even those aspects without going for the culling policy in such a situation. So under that circumstance, we have to consider about these kind of surgical involvements. So then in this discussion, I will discuss about following topics: Atresia ani, rectovaginal fistula, anorectal agenesis or the colostomy as the solution for that, then removal of the tumor located around the rectum, and fixed carpal joints. Then as the solution, we may discuss about the surgical solution for that. That is about carpectomy and partial arthrodesis. So I will discuss those things within next 1 hour time. When you look at the first topic, Atresia ani, you may get complaint from the farmer within first few days of the life of that calf. It is related only with neonatal stage. You may get that kind of complaint regarding the neonatal calves. So complaint would be lack of defecation, or sometimes lack of anus. Sometimes certain farmers may notice that. So then in addition to that, sometimes they may complain about hyperexia or the reduced appetite. Then they will complain about those aspects. Then in your clinical examination, you may able to identify the defect there. Then not only that, as you can see here, as you can see in this diagram, this is the you imagine this is the end part of the GIT or the rectal area, it has originated from the endoderm at the embryonic growth. So that skin part may originate from the ectoderm. So then at the embryonic development, both that ectodermal and endodermal origin, or the GIT, end of the proximal end of the GIT, gastrointestinal tract, and the skin should fuse together, when I explain it simply, and leaving an orifice there, that is the anus. So sometimes with the embryonic developments that may not happen. So in that case, so that externally we may able to see, right, animals without anus, as you can see in this picture. So then we have to find a solution for that. So then we have to, one thing is we have to observe the protrusion or the bulging of that probable location of the anus, right? So this is the area that you have to check that just below the level of the base of the tail, right? You have to check whether it is protruding or bulging, right? So as you can see in this picture, sometimes in this first picture, sometimes you may see that permanently bulged or protruded, right, that area associated with the right probable anus. So in that case, it is right very convenient for us. So that bulging would be due to accumulation of the meconium within the anal pouch, although that rectal pouch, that anal opening is not there. So in that case, we can cut open and we can make the artificial anus for the animal. But sometimes again, we have, when you observe that area, sometimes you may notice that intermittent bulging of that place, not always, right? Especially while animal is straining, then you may see that right protrusion of the or the bulging of that probable anal area in this part, right, as you can see in this second picture, right? Then again, right, it is convenient for us. It means that anal pouch or the end of the rectal pouch or the end of the rectum is very close to the skin, right? Then again, we can cut open and we can make the artificial anus for the animal, right? So then sometimes we may not able to see the bulging even at the straining of the animal, right? Under that circumstance, we may have to think about the other possibilities even, right? Anyway, presence of atresia ani conditions, then we can try to find the presence of that rectal pouch, right, which has accumulated with meconium. For that, we have to pass 18 to 14 gauge needle, right, across the probable location of the anus. Then we have to aspirate. Then we can see if we can find that pouch very close to the our needle or the close to the probable location of the anus. Then we can see the aspiration of meconium to the syringe. Then we can understand the right depth of the location of it, right? So then we have to go for the surgery. For, as you know, before the surgery, usually we have to keep that animal in fasting, right, for a certain period under different situations. But in this situation, right, they are neonates, right, neonatal calves. We don't want to keep those animals for fasting for prolonged period. So instead of that, without keeping that animal for fasting, we can go for the sedation and anesthesia according to our requirement. Because when you keep those animals for fasting for prolonged period, sometimes that calf may die because of the hypoglycemic situation. So they are highly sensitive for that situation. So considering those aspects, we should not go for the fasting period, right? So without doing that, we can directly go for the sedation. We can use, for an example, we can use xylazine, 0.05 mg per kg intramuscularly. Then for the anesthesia, we can use general anesthesia. For that, for an example, we can use ketamine, 6 mg per kg in IV route, right? Or else we can go for the posterior epidural analgesia using 2% lignocaine. We can use 2 mg per kg, right, dose rate. Then we can introduce it through the same route, as you know, right, in between C1, C2, right, space or the sacrococcygeal junction, right? Then after the anesthesia, we can do the start the surgery. So at the surgery, right, we have to prepare the surgical site. So surgical site mean we have to find the probable location of the anus. Then we have to prepare the surgical site, as you know, as we are doing in our routing surgeries. We have to clip and we have to clean the site. Then we have to scrub the site with 70% isopropyl alcohol, 4% chlorhexidine or 10% povidone iodine. Right. Then we have to scrub the site. Then we have to make skin incision. First incision should be in vertical axis. Then another incision in horizontal axis, right, on the expected site, as you can see here in this place. So then we have to first cut through the skin, then subcut tissue, then we can see the rectal pouch there. Then once you identify the rectal pouch using an artery forceps, we can exteriorize it. Or if it is more superficial, without using the artery forceps, we can open up it, while holding using Alice forceps. So then pouch, then we have to make mucocutaneous junction artificially. It means we have to put stitches or the sutures of rectal wall, or then against the skin. For that, we can use simple interrupter suture pattern with non-absorbable suture types. For an example, we can use 0.45 G gauge nylon for that, right? So we have to, anyhow, we have to keep the mucosal layer of the rectum against the skin. Then we have to put the stitches to make the anus artificially, right? Then as usual, we have to do the post-operative care. For that, we have to apply tincture of iodine on the. It's better to use penicillin group as the first line antibiotics for the surgeries. Then we have to consider about the pain of the animal. For considering that, we can go for the analgesics, NSAIDs or the glucocorticoids, right? So then we have to have close observation about the surgical site until at least 1 week period, because that animal may defecate through that opening. It is highly vulnerable for the contamination, so maggot infestation, suture adhesion, bleeding, so many possible complications are there. So considering those aspects, we have to have a close observation of the animal, and it means we have to keep that animal in a separate place until the fully recovery. Then next condition is rectovaginal fistula, right? So another development of the congenital conditions. So here in this case, sometimes farmers may not come to you few days after, even few days after calving, right? So because farmer may notice that defecation, urination, right? Because of that, farmer may not worry within first few days, but with the time, within after several days, farmer may notice about the defecation through the vulval lips or through the coming through the vagina, right? Then in that case, he or she may come to you, right? Then with the complaint of that. Then we have to identify the fistula. For that, we can pass our finger through the vagina towards the upright, or we can pass a blunt instrument, right? So then we can we have to insert through the vagina. Then we can feel the opening of the fistula from the vaginal side. Then we can find the proper place. As you can see in this diagram, most of the time that fistula may locate posteriorly, very close to the perineal region. So in that case, to correct this, we have to, as I mentioned earlier, we have to follow the anesthetic guidelines. Then we have to prepare the surgical site, as I mentioned earlier. Then we have to put the incision starting from the dorsal commissure of the vulval lip here, dorsal commissure of the vulval lip. through the perineal region. It means we have to cut through the skin, subcut tissue, and the fistula, across the fistula like this, along the fistula, right up to the rectum. Then we have to cut the skin part right up to the level of the probable location of the anus. Then we have to separate this fistula. We have to separate the rectum from this fistula, and we have to extend that opening up to the required level, and we have to put mucocutaneous. We have to make artificial mucocutaneous junction using the previous skin incision here, right? Then meantime we have to close the fistula from the vaginal side. For that already we have opened up into the fistula. Then we have to scarify this fistula opening from the vaginal side until bleeding. Then we can make a fresh wound there. Then we have to put stitches to close the fistula opening in that point. After that we can close the skin incision close to the associate with the vulval lips here, right? That way we can correct the fistulas. So that's how we should do the correction of fistula in farm animals, right? Then next one is anorectal agenesis. Anorectal agenesis. So again, to explain that, I will use the this real case, right, that we have involved. So when you look at the history of that case, we got a 3-day-old bull calf without rectal opening. Without rectal opening. It was a referred case from a field vet after unsuccessful surgery to rectify that matter, or to correct the atresia ani. So finally they referred that case to us. Then we have done the GCE. It was normal except this complaint. Then we have done the sedation anesthesia. We have handled this case under general anesthesia, right, as I mentioned earlier. Then before do the rest of the surgery, we have done the aspiration using 16 gauge 2 inches lengthy needle, but unfortunately we couldn't see that first feces. We couldn't aspirate it. So then it means that rectal pouch would be little away from the expected level of the place, or the expected place of the anus. So that our needle was 2 inches lengthy, but we couldn't get that. So with that clue, we have decided to go for the, we have to we have to think about the other possible corrective measures, right? So then then we have decided to do the laparotomy from right lateral abdomen, not the paralamba fossa. We have done it from the right lateral abdominal area. Then after doing the laparotomy, we have done the identification of rectal agenesis, probable rectal agenesis. After doing the surgery, as you can see in this first diagram here, we have inserted hand up to the level of the towards the rectum. We could feel this pouch, right? After that pouch, we couldn't feel the rectum there. So instead of that rectum, we could feel that small band. Diameter was around 3 millimeters. A band, continuation towards the probable location of the anus. So then that could be due to rectal agenesis. So that it has the development has ended up with the level of the colon. So then we have to think about the other possibilities. Then we have decided to do the colostomy. For as the corrective measure. For that, we have, as you can see in this second diagram, we have exteriorized the part of the pouch here, part of the colon. Then we have squeezed back the content backwards. After that, we have applied the bowel clamp, as you can see in this diagram. Then, as you can see here, after application of the bowel clamp, then we have done the colostomy parallel to the laparotomy incision. Then with that, as you can see in this first picture, this is the colon, this is the laparotomy incision. Then we have made a mucocutaneous junction artificially, using the mucosal layer of colon and the skin of the abdominal area. So using the non-absorbable, non-absorbable suture material, nylon, or we can use a simple interrupted suture pattern for that, that is more steady, more stable for the condition. Then we have used that. Then again, we have to do the post-operative care, as I mentioned earlier, we have given antibiotics and analgesics, wound dressing for until 1 week time. So we have done that part. Then with the fully recovery, we have discharged that animal, 7 days of hospitalization period. As you can see in this picture, here you can see the colostomy that we have done parallel to the laparotomy here. Then we have put stitches or the sutures, keeping that mucosal layer of the colon against the skin, and we have applied sutures, leaving an opening here, So in second picture, you can see the surgery here. I think you can see it now. In second picture, this picture, you can see the opening clearly, immediately after the surgery, So here you can see the after application of the wound dressing compound here, We have kept that animal for 7 days. Then after the 7 days with the fully recovery, we have discharged that animal. Then here you can see that animal after 3 weeks from the surgery, from its original or the site or the place or the farm, Then here you can see the same animal after 3 months after the surgery. So here I'm going to talk about that removal of tumor around the located around the rectum. Sometimes you may get this kind of complaint. To explain that, I will use this real case that we have handled. When you move to the history, it was a 2 years old female Frisian heifer, due to inability to perform the per-rectal examination at the AI, they have complained it. They have informed it to the farmer. Then that interesting thing is, farmer has noticed that even from the very beginning, it means at the neonatal stage, but he has not worried about that because he was not much aware about this farming as a beginner. Then finally they have referred that case to us. Then in our clinical examination, we could find that round firm mass around the posterior rectum. So here you can see the protruded rectal area with a bigger mass. So then here you can see the very narrow rectal opening. When we check the rectal opening, we could insert only 1 finger through the opening. So diameter was around 1 centimeter. So then we have decided to correct it surgically. Under that situation, we have given pre-anesthetic medication to the animal because we have to do the surgery in a well-developed animal, and we have to do the surgery associated with the rectum, so it is highly vulnerable for the contamination. So considering those aspects, we have given magnesium sulfate orally, 200 milligram of magnesium sulfate dissolved in warm water. Then we have given it as lukewarm water solution. Then we have drenched 6-7 bottles of water, and we have provided enough ad libitum water to the animal. Then we have kept that animal fasting for 2 days, and for water we have kept that animal for 12 hours. During that period, we have given 10% dextrose, LRS, and saline to compensate the requirement of the animal. At the surgery, we have done the sedation using 2% psilocin with mild sedation using 2.5 mg per 50 kg intramuscularly. So we have done the surgery while animal is in standing position using posterior epidural anesthesia. For that, we have used 2% lignocaine HCl. We have initially used 4 ml lignocaine, as you can see in these pictures. I think now you can see that slides. So after induction of that, we didn't separate the syringe. We have kept it with the additional amount of additional 4 ml of 2% lignocaine there, right? Because we couldn't estimate the required time. So if it's a long-lasting surgery, we have to introduce more. So while you are doing the epidural analgesia to the cow or the calf, we have to insert 18 gauge hypodermic needle in between sacrococcygeal junction or the C1 C2 junction. Then before release the drug, we have to make sure whether you have passed that needle into the proper place or the epidural space. To make it sure, we can, while you are passing the needle, we can try to hear the pop sound. Then if it is in the proper place, you can hear the pop sound, or else we can, as you can see in this picture, we can put few drops of 2% lignocaine to the hub of the needle. Then if it is in the proper place, freely it may move to the epidural space, or we can connect the syringe into the hub and we can aspirate it. Then you will see bubbles coming to the syringe. Or else we can try to release the drug. Then if it is in the proper place, you should be able to release the lignocaine without any resistance. When you aspirate, if you can see the blood, it means you have passed that needle into the subarachnoidal space. So we have to adjust under that situation. So then at the surgery, we have done the we have washed the surgical site, then we have scrubbed it. Then we have done the circular skin incision around 1.5 inches away from the rectum. So then circular manner. Then we have done the blunt dissection between tumor and the probable tumor and the surrounding tissue. Then we have exteriorized the rectum with the tumor mass, as you can see in this second picture. This is the anal anus. Here, this is the probable tumor mass. We have separated from the body. We have separated the proximal part of the GIT from the body. So then we have separated the tumor from the rectal wall. So, but unfortunately, we have to remove a part of rectum, most posterior part of the rectum, due to the weakness of that wall, right? So very thin, weak wall, presence of thin, weak wall, we have decided to remove that part, right? Then we have, using the remaining edge, we have made an artificial mucocutaneous junction in this surgery. So then after that, we have to do the post-operative care very carefully. We can use antibiotics, tetanus toxoid, then analgesics, NSAIDs or glucocorticoids. We have to do the wound dressing until fully recovery. We have to have close observation to prevent the contamination. And then we have to. Here you can see the removed tumor mass. Here you can see the part of the rectum that we have separated, removed, right? So then here you can see the new edges of the proximal part of the GIT. Then using this mucosal layer, we have done the we have made the artificial mucocutaneous junction using non-absorbable type suture material using nylon. 0.45 nylon. So then here you can see the picture immediately after the surgery. Right now here you can see the considerably bigger opening here. This is immediately after the surgery. This is 2 weeks after the surgery. Right. So before discharge the animal, after the fully recovery, we have checked whether we can insert our hand rectally or not. So with that, with the successful surgery, we have discharged that animal. Not only that, we have sent that tumor, or the probable tumor sample for the pathological diagnosis. Then, according to the histopathology, we could diagnose it as fibroliomyoma. Right, that's a it is possible. Right, it's a possible tumor, benign type tumor, which can organize around hollow organs, especially vagina, rectum, then uterus, right, organs like that. So fifth one, so last technique is correction of flexed forelimb, especially at the carpal joint, right? So again, to explain that, I will use this real case. When you look at the history, we got that 20 days old Frisian Jersey Sahiwal crossbred female calf. So the complaint was inability to extend the left forelimb at the carpal joint since birth. So in our GCE examination, we couldn't find any abnormality other than the complaint. So then so we have taken an X-ray, but unfortunately it was having very low diagnostic value due to the certain errors in that images. So, but with the close examination of the X-rays, as you can see here, and with the palpation, we have drawn, we could identify certain defects there. Right, according to that findings and feeling, we have made this image, considering about the possible malformation in the carpal joint here. So then according to our identification, so as you know that in the carpal joint there should have two layers of carpal bones, so proximal layer and distal layer. Then within that each layer there should have three carpal bones, so medial, lateral and mid. So then there should have 6 carpal bones in the carpus. So but according to our identification diagnosis, we could feel like that. Other than that, carpal bone should locate across the carpal joint, but here we could feel only at the anterior part of the carpal joint. We couldn't feel two layers there. So then we have identified it as like this. Then so we have decided to do a surgery to try to correct it. So then we have done the sedation and anesthesia, as I mentioned earlier. We have done this surgery under general anesthesia, using psilocin ketamine. So as you can see in this picture, we have done the vertical incision along the carpal joint. Then meantime, we have done horizontal incision as well across the carpal joint here. Initially on the skin, then we have opened up until the carpal joint. So while we are doing that incisions, we have to cut certain other structures as well. So we had to cut tendon of the extensor carpi radialis muscle, then accessory cephalic vein, branches of the radial artery, then part of dorsal arterial plexus. Those are comparatively blood vessels are minor type blood vessels, though there's a possibility to for anastomosis. So then we have separated those part. Then we have opened up into the joint through the joint capsule. Then we have done the carpectomy. We have removed the carpal bones. As we guessed, we could see only 2 carpal bones, as you can see here. right? Medial and lateral, only 2 carpal bones instead of 6 carpal bones. Then we have decided to remove that part, carpectomy. Then right, separated the interosseous ligaments using a scalpel blade, and we have removed both medial and lateral carpal bones, as you can see in these pictures. Right. So after that, although we have tried to extend the limb, it was not sufficient. Then under that situation, we have decided to do the partial arthrodesis. So in then epiphysis of radius ulna and metacarpal bones. As you can see in this picture, I think you can see my slide. Am I correct?
Yes, sir, we can see.
Right. As you can see in this right diagram, you may pay your attention on these white lines, right? So that was the expected right incision line across the right epiphyseal part of the right bones. We have decided to remove a right slice from both the radius ulna side and metacarpal side, right? Then we have removed the wedge shape slices from the cranial epiphysis to mid of the articular surface, not right totally, not across the right entire epiphysis, only up to this level, right, in a wedge shaped manner. As you can see in these real pictures, we have cut and remove this to wedge shaped bony parts, right? So then we could extend the limb up to the expected level, right? Then we have removed the excess part of the right joint capsule, overstretched part of the joint capsule. Then remove the excess part of the tendon of the extensor carpi radialis muscle and the skin. Then we have applied sutures to the joint capsule, then to the extensor tendon of the extensor carpi radialis muscle. Especially when we apply sutures to the tendons, we have to use tension type sutures. Here we have used that cross mattress type. So instead of that, you can use the far near far, near far, right? Different types of tension sutures are there. We can apply one of that for the right tendon. Then we have right close the right skin using right non-absorbable type suture materials. So then again, we have done the post-operative care very carefully until fully recovery of the animal, right? So then not only that, after the surgery, as you can see here you can see immediately after the surgery, right? Then we have provided additional support externally. For that, we have specially prepared this metal splint. Then we have wrapped it with cotton wool. Then we have fixed it, as you can see in this third picture, right, to the limb, right? Then we have removed that after 2 weeks from the surgery. Here you can see the right surgical site 2 weeks later. Then this is 1 month after the surgery, right? We have without any right external support. Animal started to use that leg while walking. So then when we compare with the other leg, right, it was 0.75 inches, roughly 0.75 inches shorter than the other one, but animal right used to use that leg right without any trouble. So to get more information, you can go through this website and YouTube. So then you can see the relevant videos and the right papers regarding that. And thank you very much. Especially, I would like to extend my sincere gratitudes to the different owners of several pictures, because I have taken few pictures from the internet to explain this. So I must thankful for the real owners of that pictures and the organizing committee and all the participants. Thank you.